So dear colleagues and friends, I'm Subhash Kaul from Hyderabad. I welcome you to this stroke webinar. And this is actually in a series by Dr. Nathan Bonstein. Everybody knows Dr. Bonstein. He has been coming to India very regularly since past decade. He is director of the brain division in the Share Zedek Medical Center, Jerusalem. He's chairman of the Israeli Stroke Society. And it would not be wrong to say that he is father of modern stroke care in Israel. He's also an eminent neurologist. He's one of the very active members of the World Stroke Organization, has served as its vice president for many years. And today's topic is a very important topic. It's about post-stroke depression, because stroke management is not only acute stroke. After the few days of acute stroke, the patient is with us for the rest of his life. And the depression plays a very important part in the patient's post-stroke symptoms, in his recovery. And in fact, there is a lot of data which says that treatment of depression may help in stroke recovery, even the motor recovery. Now, a lot of papers are there, and Nathan is the best person who will illuminate us on this subject. Please have your questions and send your questions and answer. After the end of the talk, I will raise up your questions with Nathan, and he'll be happy to answer your questions. Over to Professor Nathan Bonstein.
Thank you very much, Subhash, and thank you for having me to give this lecture on post-stroke depression, diagnosis and treatment. Before I start, I just want to dedicate this session to the late John Doris, who was my mentor in Toronto when I was there in the mid-80s. And he passed away just about a week ago for the COVID-19 in London, UK. So this lecture is dedicated to a great mentor, an amazing clinician, and a wonderful person. And that I'll miss, and all the stroke community will miss. So this is for you, John. So what we have here, I think that most of us will deal on post-stroke physical disability, and the emphasis is on post-stroke physical disability, rehabilitation, motor rehabilitation, but we should not forget that the consequence and the complication of stroke include also the cognitive, emotional, and behavioral disability. And I think that up till now, the physical disability is just the tip of the iceberg. We should not forget the non-physical disability, personality changes, depression, emotionalism, memory loss, and other behavioral consequences of stroke. And the depression is one of them, and I'll concentrate now on the depression part. And the DSM-5 define depression as permanent or persistent mood disturbances characterized by depressive mood, of course, and lack of pleasure, anhedonia, causing distress or impairment in social, occupation, or other function. This is the current definition by the DSM-5 of depressive disorder due to stroke, what we call post-stroke depression. There are many scales that probably you're familiar with some of them to screen for depressive symptoms. The most kind of commonly used is the Hamilton Depression Scale, Hospital Anxiety Depression Scale. We use in our studies that I'll show you immediately is the Geriatric Depression Scale. However, each one of them has some kind of limitation. Some of them are self-assessments. Some of them cannot, because of the denial of the patient, they cannot assess it. A phasic patient cannot be assessed properly. So each one of them has its own limitations, but you can use whatever you want. So why is depression or post-stroke depression so important, why we're talking about it. The idea is that post-stroke depression is more prevalent than we think. If in many studies, there is shown that about 20% to 1/3 of patients will have post-stroke depression. Depends if it's inpatient in the hospital or outpatient in the outpatient clinics. But definitely many of them they will have persistent depression, and about 55 of them will have major depression. So if we look at depression, in general, approximately 1/3 of all our stroke patient survivors will suffer from post-stroke depression. And it's not just, it's very prevalent, but depression is strongly associated with further worsening of our physical as well as cognitive recovery, and it's negatively affected patient ability to engage in rehabilitation. If you're apathic, you don't have an energy, lack of energy, you don't want to participate, neither in rehabilitation nor in integration back into the community. So depression is a major issue as after stroke, and we should not neglect it. So if you look, this is from José Ferro from Portugal, Lisbon. If you look at the items or the domains where depressive disturbances are affecting outcome, first, it is associated with high mortality, more disability, high risk of stroke recurrence, level of social functioning. Nowadays, we are talking about the loneliness effect. The depressive is actually patients are lonely, so it affects your life and quality of life. And of course, family caregiver depression. Caregivers are also affected by the depressive symptoms of a post-stroke patient. So if you look, what are the risk factors? Why some people, if it's 1/3, means that 2/3 of our patients will not develop depression. So what are the risk factors that are associated with post-stroke depression? So there's a list that you can see by yourself: female sex, past history of depression, of course, psychiatric illness, functional limitation. I mean, the more disabled you are, the most likely that you will be depressed. If you are, before the stroke, you were fully functioning person, and cognitive impairment. So what are the predictors of persistent depression after stroke? Is the lower level of pre-stroke social activity. If you were sort of inactive before, you are more likely to develop persistent depression, greater severity of stroke, which is obvious, and lower level of function at baseline. I just would like to share with you a bit of our very spicy study called Tabasco in Tel Aviv. Tabasco stands for Tel Aviv Brain Acute Stroke Cohort Study. And this study is single center, which about 600 patients. We followed them for 8 years. They all were first ever ischemic stroke, mostly mild to moderate, because we like to have them for long-term follow-up. And there were over 50, and they were not depressed and did not have cognitive decline prior to the index stroke. And we, at baseline, we did a lot, very extensive and intensive investigation, including MR, 3 Tesla MR, a lot of biological markers for inflammatory markers, cytokines, cortisol, for stress, etc. We have questionnaire for depression, and of course, computerized cognitive assessment, and also MOCA, the program, the software was called Neurotrack. So we did all this at baseline, and then we followed them for 6 and 12 months, and then annually with all these parameters assessed every visit. So if you look at what we have found for depression and stress, and this was published in Journal of Psychiatry in 2016, you can read it yourself. So we found that in general, depressive, immediately after the event, about 15% have global depression score on the GDS, and 6 months later, about 20% will have a GDS, geriatric depression scale, above 6, which is depressive symptoms. But if we look in a multivariant analysis of those with GDS above 6 at admission and at 6 months post-stroke or TIA, as I said, it was minor stroke or TIA, there was significant association between the GDS and cognitive impairment, controlling for all the other variables. And this is just to share without going into detail. If you look at all the domains, like integration, participation, and quality of life, those with GDS above 6 means that they were depressed at baseline at 6 months, did worse in all these domains, including cognitive decline. So this is another tip, another piece of information to show that actually depression or depressive symptoms, not necessarily major depression, are associated with functional or worse functional outcome. What is the mechanism by which a single lacunar infarct or a small infarct somewhere in the brain will cause depression? So there are at least 3 possible explanations, as you can see. Either it's coincidental, because the patient was depressed before, and this was just a trigger, or it's a physical disability consequences, because all of a sudden you become disabled from a fully active life. You become disabled, that, of course, will cause depressive symptoms. Or there are another potential mechanism is the neurotransmitter imbalance. So this is so we actually divide the mechanism or potential mechanism between neuroanatomical theory and psychological theory. Neuroanatomical is assuming that the post-stroke depression is caused by a lesion that are actually involved the disruption of frontal or left frontal area and affect the neuron circuit involved mood regulation. And it was proposed the disruption of this neuroaminergic pathways and the depletion of these cortical biogenic amines due to disruption of this frontal subcortical circuit. This was actually proposed by Robinson, that showed that basically the left frontal lobe is lesion in the left frontal lobe is mostly associated with depressive symptoms. However, I think that basically we can all assume that it's a multifactorial origin, either by lesion location, psychological factor because of your disabled, and you can say that lesion localization is involved in the early post-stroke depression. However, the psychological factors may be associated and involved in the late post-stroke depression. Having said all that, and I think that you appreciate that it is a prevalent problem after stroke. This problem affects our patients' outcome, and it's involved many factors that and risk factors that are associated with post-stroke depression. The question is, what can you do? Having said all that, can we treat to prevent this effect on this subgroup of patients that are more likely or more prone to post-stroke depression? So there were several cohort studies, and I just show you some of the data of intervention for treating depression after stroke. This is from the Cochrane Library back in 2008, already 12 years ago. They included 16 trials with 17 different interventions, including 1,600 patients, 1,600 patients. And you can see that there were 4 psychotherapy trials that couldn't show any evidence of benefit, and about 13 pharmacological therapy, mainly with SSRIs versus placebo, or tricyclic antidepressant versus placebo. And the conclusion of this review or meta-analysis by Hackett showed that antidepressant drugs may produce recovery or improve depression symptoms. However, they also found that these drugs may cause increase in adverse effect, which might sometimes offset the benefit of the SSRI. In 2012, about 4 years after that, there was another Cochrane meta-analysis of the only on SSRI as an intervention to prevent post-stroke depression. The objective was to determine whether SSRI improve recovery after stroke and whether treatment with stroke is associated with adverse events. They included 56 completed trials. Most of them were small trials. 4,000 patients, more than 4,000 patients were included. And the conclusion was that SSRIs appeared to improve dependence, disability and neurological impairment, anxiety as well as depression after stroke, but most of these were small trials, and there was heterogeneity between trials and methodological limitation in the subpopulation. So they conclude, as you know, the Cochrane is usually said, okay, there's some signal of efficacy now. Large and well-designed trials are needed to better see whether SSRI should be given routinely to patients with stroke, routinely. So in 2017, there was another meta-analysis done by the American Heart Association, American Stroke Association, scientific statement, and they include 8 trials of pharmacotherapy trials. The conclusion was may be effective. Psychological intervention, 5 trials, may prevent, it's all may. And psychological and information provision, many small trials, but none of them were actually with firm conclusion to say that we should treat our patient, all our post-stroke patients, with antidepressants. The first well-done small trial in France tested actually whether fluoxetine will be beneficial for motor recovery after ischemic stroke, not just the depression, the motor recovery, assuming that if you will be better in the physical activity or physical recovery, this will also affect also the mood and other non-physical component of the consequence of the stroke. So they will be giving 20 milligrams of fluoxetine over 90 days against placebo, and all the patients receive standard care in organizing in-stroke team care. And the outcome measure was Fugl-Meyer motor scale on the upper limb and the lower limbs in the affected side. And this was assessed in 30 and 90 days. If you look, it was a very positive trial. Everybody was very excited. 2011 it was published in Lancet Neurology. And you can see that at 90 days, the difference between the progression between a baseline and 90 days, the Fugl-Meyer improved against placebo in the upper limb and the lower limb, and was statistically significant. But look at the numbers. 56 patients in one arm and 57 in the other arm. Small study, but positive. Everybody was excited. And these are just the bar, what we call the grotto bar, showing that basically fluoxetine, the 1 to 0 MRS, the modified Radcliffe scale, was much better than in the placebo group. There was no difference in mortality. And so therefore, this trial was actually the basis for a huge trials. That these were the 3 big trials: focus, affinity, and effects, that were supposed to include altogether 6,000 patients. Administration, trying to see whether administration of fluoxetine 20 milligrams daily for 3 months after stroke will improve patient functional outcome at 6 months. And the first results were published in the Lancet 2019. I'm not sure whether you're familiar with the FOCUS trial. The FOCUS trial was, again, randomized controlled study. More than 3,000 patients were recruited. Half of them were given fluoxetine, 20 milligrams, and half of them were given placebo. And the data at 6 months were available for about 100 patients in each group, or 100% in each group. And as you can see here, without going into detail, unfortunately, this trial, fluoxetine to 20 milligrams given daily for 6 months after stroke, does not seem to improve functional outcome. However, the study showed that the fluoxetine treatment reduced the occurrence of depression. However, increased frequency of bones fractures, especially hip fracture. So the adverse effect was actually offset by the beneficial effect of depression was offset by the adverse events of bone fracture. And these are again, just the data to show with all these, if you look at the MRS 0 to 6, there was no difference between placebo group and the fluoxetine group. There was another study, the TALOS study. And the TALOS study this time examined the efficacy of citalopram, Cipralex, in acute stroke. This was the Danish trial. And the citalopram was given within 7 days after symptoms in non-depressed first ever ischemic stroke. And the follow-up was for 6 months. Small, again, 642 patients were included, randomized into either placebo or citalopram. And if you look at the results, early citalopram treatment did not improve functional recovery. So again, SSRI so far could not show any beneficial effect on functional outcome after stroke. And this is the conclusion of the, as you can see, from the Lancet says fluoxetine 20 milligram are actually inacute for not improved functional outcome, although there's some beneficial effect on depression. Number needed to treat to end 27. However, there's a potential increase in bone fracture among the treated group. There is another meta-analysis just showing the same 13 trials, 4,000 patients. Again, this is a class 1 evidence demonstrate that fluoxetine does not reduce disability and dependency after stroke. Very disappointing after the FLAME study that I've shown you, the French one, that showed such a significant beneficial effect. So if you look at the post-stroke use of selective serotonin uptake inhibitors, the nationwide prospective study, this again, if you look, just to show you some data, whenever you use the SSRIs, if you want to use the SSRIs in your patient, you have to look at the, and this is have effect. This SSRI has effect not just on the stroke, but if you look at stroke, myocardial infarction and recurrent stroke, it was beneficial effect. However, this is a thing that you all have to know and we have to know. There is some evidence to show that basically the high risk of major bleeding with administration of SSRI. So if you have a patient with high risk of bleeding or previous bleeding, I'm talking about major bleeding, you have to be careful when you administer SSRI. So SSRI use after ischemic stroke was associated with lower risk of cardiovascular event. However, it has increased bleeding risk. We have all to be aware of it. And another point that I would like to stress is the interaction with fluoxetine and fluvoxamine, all the SSRI, the CYP2C19 inhibitors, with Plavix, with clopidogrel. And as you can see here, patients on Plavix or these CYP2C19 inhibitors and SSRIs an increased risk of ischemic stroke because the SSRIs will decrease the anti-aggregant effect of clopidogrel. So being treated with clopidogrel, SSRIs when initiating clopidogrel may decrease the effect of clopidogrel. So patients on SSRI that come to stroke and you put them on clopidogrel, be aware that SSRI will affect will reduce the effect of clopidogrel on one end, and if you start SSRIs after stroke on patients on clopidogrel, you have to know that there is an action, just for your knowledge. So the American guidelines, American Heart Association guidelines said the effectiveness of fluoxetine or other SSRI to enhance motor recovery is not well established. Levodopa and others are not very well established. I just want to mention there is some other potential drugs in the horizon, and this is the serbrolizine. You are familiar with serbrolizine, and it has a neuroprotection and neurorecovering effect, and serbrolizine demonstrated to facilitate brain trophicity, plasticity, and neurogenesis. There are a lot of evidence from animal models as well as in human showing the effect of serbrolizine as the trophic-like factor and increase all these good growth factors, and by that increase the recovery of the brain after lesions, either stroke or traumatic brain injury. So if you look at the data, and this is one of the large studies that were conducted in cerebralizing and recovery after stroke, it's called the CAR study. It was a randomized, double-blind, controlled study. It was a multi-center study. And if, without going into details, because you can read it, it was published in Stroke 2015. And we look at all the recovery items. All the estimate points fall in favor of cerebralizing. But if these are the NHSAs, Bartel, and MRS, they are all significant in favor of cerebralizing. But if you look at depression, which was part of the pre-specified secondary outcome, or secondary endpoint, see a very significant effect with a very large size, effect size of cerebralizing on depression. And if you look, just this is the data, if you look at cerebralizing in 100 patients compared to control, there was 72% improve in cerebralizing, depression improve, compared to only 42, 43%, 44% in the control group. And if you look at those that went from shift from severe depression to mild depression, this was 2% versus 0 in the placebo group. So definitely depression, post-stroke depression was improved, and cerebralizing had a beneficial effect against control. This was in stroke. The same, also, this is not published yet, but it was presented. The efficacy and safety of cerebralizing in TBI patients. And again, this was in moderate to severe traumatic brain injury, very sophisticated way to analyze the beneficial effect in TBI is not easy, but this was they've established a very interesting way to establish a global effect on many domains in post-TBI outcome. And as you can see here, without going into details, all this, again, this is a multivariate outcome in 90 days, early recovery phase, and this is per protocol. And you can see again, or if you look all the domain together, there is a beneficial effect. If you look at depression, and this is the Hamilton depression scale, this is the Hamilton anxiety scale, definitely again, like in after stroke, you see again the beneficial effect of this, the cerebralizing against placebo. So this is the, if you look at the scientific details, and this is just a zoom into the depression part, cerebralizing measured by Hamilton depression scale has beneficial effect in 90 days after stroke and after TBI, and it's standalone significant also on day 30. And this is just to show that basically Austrian rehabilitation guidelines include cerebralizing as the first evidence-based rehabilitation, and the cerebralizing is the best assessed compound evaluated with class 2 level B evidence of beneficial effect. And this is the only efficacy and named drug in the rehabilitation guide. Another potential treatment is, of course, the TMS, and there is in post-stroke depression, only small, the magnetic stimulation, transmagnetic stimulation, and small studies. It was shown that they is safe to do it. However, the study was too small to show a fair and significant beneficial effect, but I think that the most studies are currently conducted without TMS in post-stroke depression. So if you look at the global picture of post-stroke depression. As I told you, there are some predictors. Patients with small vessel disease, especially that's where with severe stroke, with social isolation and poor coping skills, will probably more likely to develop, and female and more likely to develop post-stroke depression. However, in the treatment management up to now, we have not found the drug or any intervention, psychiatry intervention, psychotherapy, etc., is effective. As I showed you, the SSRIs were not found to be very significant beneficial effect, especially on the global functional outcome of the patient with adverse events. So we have to be aware. The cerebralizing that is emerging as a potential drug. There are currently ongoing study on cerebralizing and post-stroke depression. And I think that's what I wanted to show you, that you should raise the awareness of post-stroke depression. The awareness is too low. We don't assess normally and routinely our patient in our outpatient clinic post-stroke for depression. We should routinely screen for it, because if we intervene with every intervention, together with the family, together with the caregiver, together with maybe drugs, I think that we can help our patient, and we'll know more about it in the future. So be aware and try to get the patients assessed for post-stroke depression. And I thank you very, very much.
Thank you, Nathan, for that very comprehensive review of literature. I mean, I have always noticed that whenever you give talks, you comprehensively review the entire literature, and you are a very realistically optimistic neurologist. You are optimistic, but you are realistically optimistic. So while you will tell us about the advantages, you will also tell us about the side effects, but at the same time, you are optimistic. So thank you very much. And I would now start the question and answer session. We have many questions, and I think you can, because some people have joined late, many of these questions you have already addressed in your talk, but some people joined late, so it will be a revision for us so you can quickly answer. So the first question is, all questions are about today's talk of depression and stroke. So the first question is, what is your take on fluoxetine in motor recovery in flame? You already said it, but you can maybe say it again. Motor recovery in flame. Nathan.
The motor recovery in flame was positive. It was a small study, and with a very positive effect on motor and limb function. Motor limb function, that is not talking about depression, but the functional outcome in MRS was positive. However, unfortunately, in a large scale trial, this fluoxetine was not showing any beneficial effect. I'm talking about more than 3,000 patients trial, and there's another one, the affinity will be published soon, and I still don't know the result, but then they will combine this affinity and focus together. There will be many patients in the pooled analysis, and we'll see. But so far, there is no recommendation to treat all patients. Of course, individual patients, if you see the patient is depressed and there is no kind of, is not on clopidogrel, be aware, and there is no risk of bone fracture or falling and breaking the hip, then I usually put patients on fluoxetine or citalopram if I actually assess and find depressive symptoms. Or the caregiver usually complain of lack of energy, apathy, anhedonia, etc., and fatigue. Fatigue is one of the things that actually, for me, is a sine qua non to depression. And we have to be always aware that if patients complain of tiredness, the bed is kind of a very good place for me. Be aware, this is depressive, one of the major depressive, and the first depressive symptoms that increase my awareness. And yes.
Now the other question is that what is your choice of deciding about the antidepressants?
Yeah, I do use either SSRI or SNRIs. The name of the drug is not important. If it's fluoxetine or citalopram.
No, you're the 1 minute, Nathan. The specific question is that do you decide the drug based on the age, gender, associated comorbidities like diabetes, hypertension, dyslipidemia, ischemic heart disease? Are there, do these factors determine that which antidepressant you choose, since you have got so many of them now? So please.
Yeah, I usually in the elderly, I don't use tricyclic antidepressant. They may cause confusion because of the anticholinergic effect, and specifically if the patient has prostate problems or any heart problem, like arrhythmias. So CTA, the tricyclic TCA, I'm not, usually I don't use it in the elderly, and in the last decade or so, I used mostly the SSRIs. Now, again, as I mentioned, the SSRI may cause major bleeding, not very significant, but in a small proportion. So patients with comorbidities like GI bleed in the past, or definitely with intracerebral hemorrhage, I try not to use the SSRIs. I found the SNRIs, the serotonin and noradrenergic inhibitors, as a very powerful drug. If, for instance, the patient suffers from, on one hand, depression, and also from pain, post-stroke pain, then I can use either pregabalin or the Cymbalta. I'm sure that you have the Cymbalta in India as well. So duloxetine. So in this case, it depends. This might be then you take two birds in one pill, I would say. Yeah. So that's usually what I do.
Does it also depend on if patient has insomnia? Are there any antidepressants which can promote sleep and other antidepressants which can promote wakefulness?
Yes, the Miro, for instance, mirazepine, it's much better for sleep disorders. This is good for if the patient has sleep or insomnia or sleep disturbances. Then I give them a Miro, it's 15 or 30 milligrams just before going to bed. And this is my policy for this patient with insomnia.
So the other question is, how long do you continue antidepressants? How long? How many months you give them?
I think usually it takes about 6 months at least. Between 3 to 6 months to reassess the patient to see if the patient is back to normal and he is very happy, then I stop. There is some people that said, okay, there is no kind of addiction to SSRI, but there's some evidence that there is addiction, and so I try not to use it for too long time. Okay. But I think that always, again, I want to say that the drug itself is not a stand-alone intervention. The rehabilitation, exercise, integration in the community, and back to social activities and physical activities is part of the package. The drug, this SSRI, SNRI, whatever, is just a part of the whole package to get the patient back to his kind of cognitive and mood and behavioral activities.
Okay. Nathan, there's one question from my side. You know, some of these stroke patients actually may have apathy, particularly the frontal lobe or caudate lesions, which is different from depression. And many of these apathy patients may not respond that good to antidepressants. And some people have suggested that this DOPA may help there. Now, we don't know about all this. Do you have any thoughts on this apathy versus depression and their treatment?
I think it's, thank you for the question. I think it's we should differentiate between apathy and depression. They are not the same. And I think that's because if you treat apathy with antidepressant drug, nothing is there. So in some instances, if you have also a little bit of cognitive decline with the apathy, I find that the Exelon might be a good solution, because the Exelon also increase the vividity of the patient and the activity of the patient. So in this case, sometimes I use Exelon patch or Exelon drug for treating apathy, although and the dopamine was not proven to be effective in these patients.
Yeah, that is good. Exelon, you mean rivastigmine? Yeah.
Rivastigmine, yes.
Nathan, there are a lot of questions on cerebrolysin, because you have really shown some studies in favor of cerebrolysin. So first question to you is, do you yourself use cerebrolysin after acute stroke?
I use it like as a compassionate, because it's not, hello?
Hello.
Yes, I'm here. I'm here.
Do you yourself use cerebrolysin after acute stroke?
It's
in your
cerebrolysin it's not registered in Israel, so I can use it only like an off-label. I mean, I have to get a special permission to use it. And we'll start to use it now, and as a study on post-stroke depression in patients with recanalization and thrombectomy.
Somebody has asked.
Just starting.
Somebody has asked dose of cerebrolysin in acute stroke. Obviously, then you may not be answering this question, but I can answer that. That we use cerebrolysin. Yeah, you can answer, please. Go ahead.
No. I think that the studies are between 30 to 50 milliliter per day. This is the treatment. This is the currently, and also we've learned from the recent study that I've presented that in these patients you can give it for 10 days or 21 days, and then you have to give boosters.
Yes.
Along the day. No, it's not just one, let's say 7 days or 10 days shot, and that's it. You have to give booster after that. I don't know what is your experience in India.
No, you see, in India, now they have come out with cerebrolysin tablets. I don't know whether there are any studies or that or not. Main studies were intravenous studies where they have to be given for 2 to 3 weeks. But now tablets have been marketed in India, and many of us give these tablets, 90 milligram tablet for 3 months. But that is just,
I'm not sure that this is evidence-based. The evidence-based is on IV.
That's correct.
On IV. So
that's correct.
You can do whatever you want, but if you look for evidence-based medicine, it's IV.
Correct. I agree. The evidence is for IV. And I think next question you already answered is how long this IV cerebrolysin to be given after acute stroke, which you already answered.
I just said it. If you look at the studies, they're between 10 and 21 days.
Yeah. Next question is, does cerebrolysin improve depression? You have already answered that. It does.
Nathan, do you keep the patient indoor for 3 weeks to give?
This is one of the problems that to leave the patient in the hospital for a long time, like more than 10 days. In many cases, in many instances, it's impossible. So you have to find this, the way how to bring the patient as an outpatient to the outpatient clinic, in order to, there's a day hospitalization. In Israel, there is such a thing that you can bring the patient for day hospitalization, give the IV any treatment, and then the patient go back home to not staying in the hospital. That's the only solution.
Okay, I think Subhash has got blocked. What has happened to Subhash's phone? Somebody's asked.
Hello. Yeah, I'm here.
Yes.
Yeah, Nathan, the other question is, what do you is there any data on the allergic reactions with cerebrolysin? Because many people have experienced allergic reactions with cerebrolysin.
I'm not sure whether it's allergic reaction or some kind of, it's what I know about is that if the drug is not kept in a proper way, this may cause sort of allergic reaction or some fever, but usually, and I've been involved in the several studies on cerebrolysin, and the main one was the Castor one with more than 1,000 patients. There is no any concern about adverse event or safety of cerebrolysin. Every drug can have some kind of allergic reaction and things like that, like any drug. But there was no differences between, in all the studies, there were no differences between cerebrolysin and placebo in terms of side effects.
So one question is that should we use cerebrolysin in all stroke patients, irrespective of their type, whether they are hemorrhagic or ischemia, and irrespective of their severity, whether they are lacunar or large artery? Can we use it as a, one for all kinds of stroke?
This is an excellent
hemorrhage,
question.
ischemia, lacunar, non-lacunar, cardioembolic, should it be used all across the board?
We know
as per the studies available.
Yeah, the data that are available is on ischemic stroke. First, there's anecdotal cases also of hemorrhagic stroke, but the data is on ischemic stroke. One. Two, if you look at the all patient, I can tell you for the sub-analysis of the cerebrolysin data, it seems that the best, if you have a mild stroke, there is a ceiling effect in the randomized control study that couldn't show that cerebrolysin is better than the placebo. However, if you look at the moderate to severe stroke, 10 NHSS, 12 NHSS, above 9, let's say, these have shown a significant effect, not just on the depression, but also on the functional outcome by the MRS and Bartel scale and NHSS. So I've published a meta-analysis on all the studies, that very thorough meta-analysis that actually show the definite efficacy of cerebrolysin on functional outcome, MRS, NHSS at 30 days and 90 days, and also on cognitive. I'm not showing the cognitive. If you ask me to give a talk on cognitive, I can show you also this, but on cognitive, and as I shown you, this was the secondary endpoints on depression. So definitely, if you look at the ischemic stroke, moderate to severe group, this is the group that should be treated, because if it's small, if you have an NHSS small, we don't know about long-term. Although, if you look in depression itself, we've shown that depression is not necessarily in severe strokes or moderate strokes. They may occur also in mild strokes. So maybe cerebrolysin is good. If you look at depression itself, maybe cerebrolysin is good also for mild, moderate stroke to severe stroke.
Okay, now the other question is that because cerebrolysin has been promoted as a neuroprotective agent. Now in India, there are other neuroprotective agents which have been marketed since many years. One of the most prevalent is citicoline and piracetam. So is there any data about citicoline and piracetam in post-stroke depression or recovery, according to you?
I have to say that I know piracetam, there is no data to show that piracetam is actually effective as a neuroprotective. Citicoline was tested in a huge study in Spain and the Hebrew Spanish group, and it was negative in terms of functional outcome. And in terms of, as I said, for cognitive, I don't know about depression, but if you talk about neuroprotection and neurorecovery, there is no evidence that citicoline in the literature, in meta-analysis. Again, there is a lot of problem with the meta-analysis because all the studies were small, and also the heterogeneity between the studies. In 2015, there was a Sabina study that have shown that there's no actually effect.
Yeah. So there's also a question about the role of Adaravon. It's a Japanese drug which somehow FDA approved.
I'm sorry, but I cannot tell you because I know the drug, but I'm not familiar with the drug, and I'm not actually very acquainted with it. So I cannot say anything about the Japanese. But if you look, I think that the difference between, you're talking about neuroprotection and neurorecovery, they are two different things. Neuroprotection is in the acute phase. What I've shown with cerebral license, that is actually the claim is that it's a neuroprotective drug, a neurorecovery drug, not in the acute phase, which is neuroprotection. You have to give it a long term and look at the neurorecovery. That's what we've seen with cerebral license, that the long-term recovery is better with cerebral license against placebo, and not necessarily the neuroprotective effect of it, but neurorecovery effect. Like being a biological trophic-like medication, and there's a lot of data to show. It's Michael Chop from Detroit that shown a lot of data how this actually works.
Nathan, there's a very interesting question on the role of CNS stimulants in post-stroke depression. Now, if you remember, there have been studies on amphetamine and methylphenidate earlier on. So is there any, do you have any thoughts on CNS stimulant?
All this data on these stimulants, so enhancer, what we call the brain function enhancers, were not, it was done, first of all, it was done many years ago. And there was only small studies with actually no beneficial effect shown, significant beneficial effect in the randomized control study. But there were very small studies on this. So in the recent years, I've not heard of any large study that was conducted on these enhancers.
There's one question on neurotracks. I don't know what is neurotracks. Neurotracks can be accessed in India, and how much does it cost per year? You understand this question? Neurotracks can be accessed in,
Neurotracks is the tool.
Okay.
If I understand, that's what we use. Neurotracks is
and how much does it cost per year?
No idea.
Cost.
I don't know, but
Okay.
I don't know. But this is the tool. This was tested. This is a computerized cognitive assessment tool, computerized, and I don't know about the price. We are using it because it was actually introduced in Israel, and we've done our studies with neurotracks. It's been validated in large populations in different parts of the world. So it's and you have normals for different ages in the population. So,
I think the Oxford group is doing another this sort of cognitive testing, which
so many of them.
Eris was doing it.
Yeah.
They did it for
Cambridge,
stroke
Cambridge.
So I think that test, Cambridge.
The Cambridge,
sorry,
yeah, the Cambridge has a different assessment, and the CanTab. There's many ways.
CanTab. It's called CanTab.
Exactly, the CanTab, and this is the Cambridge group, and many people use it, especially in Europe. The CanTab.
So is NeuroTrack something like CanTab?
No, it's different. It's in different domains and a different way of conducting.
Okay.
No, Eris has already completed one on the general population to find the, the normative data. They have finished that part, and now they will go to the next stage. So,
Yeah.
Nathan, can you hear me, Nathan?
Yes.
Nathan, can you hear? Yeah. So we come to the end. With that, we come to the end of the question answer session. I must say that was a very informative session, and I'm sure all of us are going to use cerebrolysin much more than what we're doing before, because stroke is such a desperate situation. We want to do anything, whatever help to the patient. Nathan, I will also ask Sudhir. Yeah.
It's a good fact, and I have to say that I don't have any shares in the company, so don't.
No. So Sudhir,
I'm not promoting it, but it's an excellent idea to use it.
This is about intravenous cerebrolysin. We cannot give oral tablets on the basis of the intravenous. So
no, I think Sudhir, just now Dr. Butch, my friend from Baroda, neurologist there, he has sent me a message that it is not same, it is cerebroprotein and this is cerebrolysin. I think we have to go over and study. They are different.
It's not the same.
Thank you, Dr. Butch.
So they are similar, biological similar drug, but it's not the same. If you want to use it, evidence-based medicine, in only the original drug that is tested, been published, and you can look at the publication. This is the only way to go.
So Nathan, before I hand over to Dr. Sudhir, because I would want Dr. Sudhir to give final comments, I would just want to tell you that you are a real friend, because the first stroke webinar was given by you, and the definition of a friend is who is there with you in the beginning and who is with you till the end. So what we are going to do now, you have been with us since last more than a month. Now we are going to have a series of stroke webinars in which they will be theme-based webinars. Each theme will be for about a month. These will be weekly morning stroke sessions or other subjects. And in strokes, we would always want you to have as one of the speakers. You can join other stroke seminars also, because your review of the literature is, as I would again summarize, optimistically realistic. So thank you. Thank you, Nathan. Sudhir, would
Thank
you
you
please
very
give
much.
final comments?
It's a pleasure and honor to be with you, and whenever you need me, I'm here.
Yes. And
Sudhir, can you do the final comments?
I just had the same thing to say to you, that you've been there, you were willing to adjust the dates, and you were just very friendly. And thank you, Nathan.
You're very, very welcome. Thank you. Bye-bye.
Thank you.